Welcome friends. I am Dr. Baldev Prajapati, Professor Emeritus and Director, Medical Education and Research, Baldev Medical College and Hospital Kadi, located in North Gujarat. These are my 4 books published in the field of pediatrics, particularly on procedures, signs and symptoms, clinical pediatrics, and very specific on OSCE, spotters and viva. Today I am going to talk on very important and common symptom, and that is the cough. All of us know that cough is one of the most common symptom encountered in our daily pediatric practice. Cough is a reflex defense mechanism of the respiratory tract. Its main objective is to read the tracheobronchial tree of foreign particles and the mucus. That means it is very important defense mechanism in the body, and unless it is required, it should not be suppressed. That is very important point which every clinician should know. If we try to understand that how this cough reflex is established, commonly whenever the cough receptors are irritated due to some particles or some substance or toxin, the afferent nerve carries this message in the brainstem and pons where cough centers are located. And these brains and pons centers are sending the message through the efferent nerve to the various organs like respiratory muscles, diaphragm and larynx. And through these organs, the cough reflex is established, and that's the thing that how the person develops this cough. Now let us know that where the cough receptors are commonly located in our body. Maximum cough receptors are in the pharynx, trachea, even paranasal sinuses, nose, ear canal, and even in the pleura with the J receptors. Friends, remember that the pleural cough receptors are stimulated by various conditions like pleurisy, pleural effusion, lobar pneumonia, even diaphragmatic hernia. And interstitial J receptors are stimulated by pulmonary edema and interstitial alveolitis. If you understand this mechanism of cough, how it happens, that first there is a short inspiration and inflation of the lungs with the air, and then there is a closure of the glottis and compression of the air and contraction of the chest and abdominal muscles, and then there is sudden opening of the glottis and generation of very high velocity airflow during exhalation, and which very classical cough is observed. If you see that what are the really common etiological principles of cough, there may be due to the airway inflammation and production of excessive mucus as seen in the bronchial asthma, or even the spasms of bronchial smooth muscles again seen in bronchial asthma, direct stimulation of the cough receptors, or there is extrinsic pressure over the airways. There may be due to various conditions like enlarged lymph node in tuberculosis or lymphoma. There may be sometimes vascular ring compressing the tracheal ring, or even some tumor or masses, or occasionally even retropharyngeal abscess. These conditions, due to the various regions, they are compressing the airways, and by the extrinsic pressure over the airway, the cough reflex is established. Let us say what are the clinical pointers suggesting some conditions. Suppose Onset is very important. If onset is sudden, hyperacute, that means previous moment child is normal and suddenly bout of cough starts, particularly in the young children, toddlers. Most common cause is the foreign body. All of us know that acute cough is very common in our daily practice as a viral etiology. But the recurrent cough may be in a case of bronchial asthma, and gradual and even progressive may be in a case of tuberculosis or congestive cardiac failure. Always go in the details of the duration. If it is acute, that means duration is 7 to 10 days. Most common is viral. But if it is chronic, tuberculosis, all of us know, is more common or some massive. And it may be even the progressive as the compression increases with enlarging lymph nodes or the mass. This is very important, I will say, graph which I want to share with you. Just look at the pattern of cough and its etiology. This was studied in one African countries and derived very important information that cough is acute in nature but with a very delayed recovery. It takes time. But cough decreasing in the recovery phase. Most common etiology is viral. But it is the recurrent cough. That means cough develops. In between the child is alright. Again episodes of the cough starts. That of the story is more common with the bronchial asthma as it is shown with the blue color graph. But if it is persistent, it's a non-remittent cough and more than 2 weeks duration, which is shown particularly in the continuous this brown colored graph, that is the characteristic of the tuberculosis. So just friends, if you go in the details in the history pattern of cough, that will give you the idea, the category or possible condition. What are the other clinical pointers? Dry cough is most common in the upper respiratory and bronchial asthma. Most of the wet cough may be in a case of bronchiectasis, lung abscess, resolving pneumonia. Even type of cough is very important. Barking cough is more common with the viral croup or laryngitis. Spasmodic cough in a bronchial asthma or allergic. Paroxysmal is pertussis or bronchial asthma. Hacking cough in tracheitis. And staccato cough is very characteristic of chlamydial infections. Whoop is a characteristic of pertussis, but sometimes may be seen in some of the infections like adenovirus, chlamydia, and respiratory syncytial virus. Severity is also very important if it disrupts the activity of the child. Feeding and even the sleep, it requires prompt action and probably we'll have to evaluate it very properly. Associated symptoms are very important like fever, probably infection. If dyspnea, maybe in a case of CCF, but if it is episodic, it may be the bronchial asthma. And already we discussed that sudden choking cough is the characteristic of foreign body in very young child or the toddler. Aggravating factors are very important. Suppose activity, that is exertional dyspnea, maybe in a case of cardiac reason. Seasonal, maybe the allergic or bronchial asthma. Nocturnal, again, maybe the bronchial asthma, GRD or postnasal drip. Posture, if you look at that, the more in the lying down position, that is again leading to GRD or postnasal drip. Even drugs like AC inhibitors can aggravate the cough. So history of drug is also very important. Even you can look at the relieving factor. Response to bronchodilators, probably suggesting the bronchial asthma. Absence of cough during the sleep and quite disturbing in the awakening stage, please, is a very important clue for the psychogenic or the functional cough. Please friend remember the cough in the neonates. The cough reflex is not well developed in early in the life and almost totally absent in the preterm babies. It is said that although it is common for the newborns to sneeze, it is uncommon for them to the cough. And if the cough is there in the neonate, it is always abnormal and we are concerned with the cause of the cough. Cough in the neonate may be due to some conditions like aspirations, in a case of GRD or tracheoesophageal fistula, maybe the chlamydial infections or pertussis. And these are the always very important and life threatening which we should keep in mind. Thank you very much, friends. Friends, before I end, I request you to subscribe our this channel, and if you subscribe every time you will get some new informations very useful in the exams and in the daily practice. Thank you. Thanks a lot.